Hello, everybody. Welcome to a new episode of IBD Essentials. It's a great pleasure to sit here together with my friend and long-term colleague, Matthieu Allez. You know that he is an immunologist, but also a clinician. Recently just moved from Paris to Montreal in Canada, and we share a lot of interests. Both of us like to treat patients, and one of the important problems we have is that we have a lot of patients with Crohn's disease who need to undergo surgery, and we still have a lot of problems in post-operative setting. We all know now that patients really are not cured and not healed like that has been expected 30 years ago after surgery. And Mathieu, I think this is one of your major areas. You really worked in this field for such a long time. You made several papers on this, and even when you really started your career, this was already very important, and I think this is something we would like to discuss. Before we really move into the topic, I could be challenging because I mentioned you're an immunologist, and I started later as an immunologist. I was more the epithelial cell biologist and liked the epithelial cells. So we were always discussing what is hen and what is egg. Are the immune cells the important, or is it more a barrier problem and we need to restore the barrier? And this is something probably which is also important with postoperative recurrence. Or what do you think?
Yeah, absolutely. So your question is about epithelium versus immunity in the process of inflammation.
Yeah.
I think it's a very good question. I mean, there are a lot of data, our colleagues working on preclinical models, like Ken Croitoru with the GEM cohort in Canada, or Jean-Frédéric Colombel in New York with the PREDICT study. They looked at samples of patients before the start, the diagnosis of the disease, and they were able to go back to even 6 years before. So the study from PREDICT, based on the sera of the American Army, actually, they identified that some patients developed antibodies against microbe or even autoantibodies as much as 6 years before the diagnosis. So showing that adaptive immunity or immunity is involved very early in the process, because you know that the process may start years before the onset of the diagnosis of the disease. And Ken Croitoru with the GEM cohort, which is quite interesting, they took volunteer people who are first-degree relative of patients who have in Crohn's, and they collected samples. And collecting 5,000 patients, subjects, they collected people who developed later Crohn's disease. And one of the first observations that they made, that they found there is an increased permeability years before the onset. So again, these are very early events. What is the primary event? We don't know. And it may be a mix of both, actually. Maybe it's not sufficient to have increased permeability to develop Crohn's, and maybe it's not sufficient to have defects in the adaptive immune system or to develop Crohn's. You need also a defect in the epithelium. So we don't know. And we don't know what is the primary event. And we know that from mice models that you can develop inflammation by targeting the epithelium, So still we are not able to desiccate, to delineate the role of each. I think you have even more ideas than me on that.
No. It's a real long-term topic. When you moved to permeability, I remember these old studies of Herbert Locks and the team where they really studied permeability using sugar tests. And now we study again the barrier function, going deeper and deeper with endoscopy and endocytomicroscopy, knowing that this is very important. But our major topic today is postoperative recurrence. And I think one of the key aspects there is that we really cannot predict for the majority of patients what will happen. And there several antibodies or tests have been tested. The pathologists had to look at the margins, the cells that they're present. So is anything of these techniques useful for you, or how do you manage the patient with Crohn's disease undergoing surgery? We can start with poker, we can continue, we can even start a little bit earlier. How do you manage your patient?
I think for now, we know that surgery is not the cure. So when we have a patient going to surgery for an ileocecal resection, so let's focus on patients with ileal disease. So ileocecal resection, in fact, most of the patients have disease recurrence. And so there is a big topic in the field, as we know, discussing with the surgeons. The surgeons with the LYRIC study claim that early surgery may be the solution for some patients. That's interesting. And in fact, in clinical practice, we have to decide between some patients, surgery versus medical therapies. And so we'll have the 10 years data of the LYRIC study actually during the meeting of ECHO. And I think for me, one key aspect is to talk about postoperative recurrence, because if you decide to do surgery, we need to know better what's happening after. Can we change the natural history? So from I've been working on that. I should mention that I've been inspired very early in my career by the work of Paul Rutgerts from Leuven, who was quite incredible.
Yeah.
He really developed the concept and he showed the role of the flux and the reflux from the colon. What he did was really beautiful, and he worked with Gerdens people and still the Leuven, Séverine Vermeer and Bram Berstock and Marc Ferrante. These people are working on the model, and it's quite fascinating. And in France, we did a study 16 years ago. We started the Remind cohort. That was a crazy idea. And we have now more than 1,000 patients included in this study. And the idea was to include patients who have ileocecal resection, to use the primary endpoint, which is postoperative endoscopy, because in fact, most of the patients will have endoscopic recurrence, and the severity of endoscopic recurrence, as shown by Paul Rutgerts, defines the long-term outcomes. So we use that, and we do multiple biobanking, and we analyze, and now we are still analyzing it, the role of the microbiome, of T cells, of the epithelium, of genes, gene transcription. We even start to look at epigenetic antibodies in the serum. So I hope with that we will be able to identify, as we discussed, different subtypes of disease. And maybe we will be able to show that some subtypes have different defects at different levels. I don't know how we're going to make it, but I hope we're going to make it, looking at genes, DNA and gene variants, looking at epigenetic markers, looking at gene transcription by RNA-seq single cell. I hope we're going to be able to move forward. And for clinical practice today, because I'm sorry, I forgot your question. Okay. The question was about clinical practice.
No,
right?
Before we move to clinical practice, this was really perfect.
Yeah.
I would really like to stay here because you are really involved in this trial. So when are we expecting results? Because you mentioned it's 15 years now going. You have a huge collection, and I come immediately with the tough question. Everything so far failed to predict the post-operative recurrence. You mentioned now different areas. Will it be a single marker? Will it be a combination of everything? Will it be easy to use, or will it be complicated?
So it's interesting because in parallel with working on different omics, gene, whatever, everything I said, we realized that we need to work a lot on clinical data. Because if we want to make improvement we need to really well characterize the patients. And actually we have a paper which should be published soon, I hope. And we looked at the clinical predictors. And very interestingly, we identified new predictors. And the main predictors so far are smoking. Smoking is bad for Crohn's. And even if you are a smoker at time of surgery, it has a long-term effect. So it's a clear risk factor. The second one is male gender. So we discovered that 6-7 years ago, and it has been confirmed in other cohorts. Male gender have a higher risk of endoscopic recurrence and clinical recurrence. Previous surgery is a risk factor. And for the first time, we show a new risk factor, which is previous exposure to biologics. So it becomes difficult. If you have received biologics before surgery and you're operated because of a biologic failure, then you have a higher risk of recurrence. So we could discuss why. It could be a selection bias, but it's a very important clinical parameters. And just to finish, using the model, using all these predictors by working on really with statisticians, we can predict somehow with an AUC area under the curve of 0.7. And this is found also in collaborations with colleagues from Canada, North America, and Netherlands, Mark Silverberg and Anne-Marie De Vries. We confirm that these clinical predictors are also valid in the North American cohorts, in the Dutch cohort. So that's quite interesting. But with the clinical predictors, we are limited.
Yeah.
So we need to work on biomarkers or other ideas.
This is exactly what I wanted to ask you or to tell you, and I will challenge you. If I'm male, I cannot change it.
Yeah.
Well,
that's an interesting question. You can change.
Yeah. But does
And
it
the
help
question
if I
will
change?
be, well, we don't know actually.
Yeah.
It's different between sex and gender.
Yeah.
We don't know if it's hormone or other genes which are. So that's an interesting question.
Another important question. We can stop smoking. I think this should be the
Yeah.
major message of our
Yeah, but
podcast
smoking,
today.
it's an interesting. The best is to have early discontinuation at diagnosis. So we should not say, okay, it's okay if you stop to smoke at surgery. It's better to have stopped before.
Yeah.
Because it's a long-term effect on epigenetic markers. We know that now.
But you mentioned before that the microbiota, that the exposome, everything, the food, everything will play a role. And it would be very nice to really have the predictor or the molecular marker that really can predict something. Do you expect that something like this will not predict 100%, but will have a high likelihood will turn out of this, or are you unsure and we will stick with clinical
That's very interesting because
numbers?
we have already shown that the composition of the microbiome at time of surgery is a predictor of postoperative recurrence. We show data on the T-cell repertoire showing that clonal expansions are increasing the risk of postoperative recurrence. We found transcriptomic on the surgical specimen at the margin increasing the risk. We found also some defect on epithelial cells with Dirk Haller in Germany, Munich, working on that. We found that also some markers and the transcriptome. So we have multiple ways to do that. But the problem is that none of them is perfect individually. Second, they cannot be used in clinical practice because they are very sophisticated, complex data. So now it's by moving to more advanced technologies, trying to simplify, to identify subtypes, and then to go to biomarkers in the blood which could be used in clinical practice. I don't know how long it will take, but I think we can find things. I think the big mistake with biomarkers has been to look for biomarkers as in all patients. Maybe we need to work on identifying subtypes and then to look at specific biomarkers for each subtype.
Yeah, again, the story of having subgroups. I'm a poor clinician. I need your help and your advice what I do in the individual patient. So you made a very nice story. It is very complex. Do you believe that with machine learning, artificial intelligence, the real big array of data we will have will be easier to use, or?
That's an interesting aspect, and actually we start to work with people able to do that. And but as usual, as always, we need to first talk between humans having the ability to do it. My feeling is that we still need to have some impact and input from clinicians, from scientists, and to how to manage the data. Because so far multi-omic are not working so well, and that we need to have ideas, because these are only tools.
Yeah.
So that's what is important with AI. I think these are fantastic tools, but we need to think how to use them adequately. And I think maybe I'm wrong, because I'm not an expert in AI, but I have this feeling, and that in fact we make hypotheses and then we can test them. We need to know where to go before, and I think AI will help us, because that's true that by integrating all this data, it's incredible. And well,
I think what we need is a better stratification of the patient.
Absolutely.
And you are also with the IOIBD stratification cluster, and you did great work, and there will also appear pretty soon some more data, because as we started our discussion, surgery for early Crohn's disease, and you don't need to treat a patient for 20 years, would be probably, so surgery, in my opinion, is not always a a loss and is not always a disaster for
I
the
agree.
patient and also
I agree.
for the gastroenterologist. If you don't need to treat a person for 20 years, it's
Yeah.
great.
On this idea, I think we need to define strategies. For many patients, surgery will not be enough. We need to do surgery and to start a treatment. And then we need to make progress on that. But of course, surgery, I think in some cases is the best option. In others, on others who have clearly indication of medical therapy, and in between, it's not easy sometimes to decide. So it's one aspect.
But now I bring us back to the grounds of 2026, and we have now the patient who is undergoing the first surgery, had small bowel Crohn's disease, had strictures and fistula. Now everything is cured. What do we do with this patient? It's a 38-year-old male and he is smoking. So we stop him smoking, but then?
Well, even if he stopped to smoke, as I said before, you should consider him as a smoker because there is a long-term effect. He has been exposed to a pollutant. I think it's interesting to say that to our patients. Smoking is pollution. And when you say that like this, it's surprising, but many patients stop to smoke.
Okay.
And it's long-term effect. And you're right, male, smoking, these are risk factors, so we should take this in account and adapt the strategy according to that. Those patients will not be good candidates for early surgery because we know that they will have recurrence, for example. So working on postoperative recurrence is also a way to better define who is a good candidate for early surgery. And if you have no risk factors, yes, maybe you will have a long term without treatment. It's not absolutely sure. And beside, and that's the beauty of the thing is that in health, is that we should always talk also about food, exercise, control of body weight, good life. And I think that's the key aspect that we often neglect. And we should, because in our study, we don't look, unfortunately, we are not able to assess diet. We are not able to assess, but we have the BMI, we have the metabolomic, and maybe we'll be able to raise some aspect. But I think in our clinical practice, we have clinical data, scientific data. How do we use them for clinical practice? We should also think about evidence, how to help somebody who has Crohn's to get better outcome.
But now I'm getting tough on you. Back to the patient again. The patient. The surgeon said, I cured the patient. There is no active disease. And indeed, we make a calprotectin, we make a CRP. 4 weeks after surgery, everything is completely normal. Intestinal ultrasound looks normal. Do you start a treatment on this patient? Do you wait?
So going back to something I forgot to say is that we still do the endoscopy at 6 months. I think the POCR study showed that, and I think still the thing to do. But there is now the question of patients who should start the therapy just after surgery as a preventive therapy, as a prophylaxis, versus endoscopy-driven decision. And actually, there is a beautiful study which will come from Belgium, the Soprano study, and this should answer to this aspect. Is it better to start a prophylaxis just after surgery versus an endoscopy-driven strategy? And this, from our data, I cannot say yet. But on the other side, we have a lot of data showing us, and I think you will agree with me, that early treatment is better than late treatment. So maybe post-operative treatment is a good option for many patients because it's early treatment.
So now in this patient again, we are 1 month or 6 weeks after surgery, and according to our previous definition, it's a sort of a higher risk patient because smoking, extensive
so I start a
involvement, and you would start a therapy and would not wait in this type of patient.
Okay. But I will do the endoscopy.
I definitely agree.
We will start a prophylaxis because it's at risk, and we do the endoscopy. And if there is recurrence, we need to decide about optimization or switching to another therapy. And that's key today for our clinical practice.
And now I make a different case. 50-year-old female patient, never smoking, and more or less limited disease, just one single stricture.
And no biologic exposure before surgery.
No biologic exposure before.
So she may be at low risk. Like she's at low risk. Still, we need to do the endoscopy at 6 months. But maybe this patient, we will not need to give a biotherapy just after surgery.
Okay, I also definitely agree. So we are in line here.
Yeah,
Now-
you're in line, but we will need to take in account the soprano data.
Yeah.
It will be interesting to
But
see.
we don't have the soprano data.
No, we don't have this yet.
And,
Yeah.
and now for the end, just one point I would like to address. If you start the therapy, how would you start? Would you go for what was done a long time ago, thiopurines? Would you go for 5-ASA? I know what you answer, but I'm pushing you.
Yeah.
Would you go to a biologic, and which biologic would you choose?
So 5-ASA, very small effect. Even if early study shows an effect, I think today that's not.
No, yeah.
Thiopurines, we used a lot thiopurines, and in fact in the REMIND cohort, but we don't have so much patient, but we don't see an effect of thiopurines in the era of biologics.
Yeah.
It was clearly efficient before, but now in the era of biologics, we don't see an efficacy.
And the data of the trials are also not that convincing.
Exactly. The data from the UK study from
So
Jackson
when you do
and
something,
Kennedy.
you use biologics?
Yeah.
And
Which one?
biologic?
Actually, we will have more data coming in our consortium called IMPACT. We will put the REMIND cohort with the North American and the Dutch cohort together. And we have now big numbers of different biologics, because in REMIND we started to look at the efficacy of biologics. Still anti-TNF are very good. But when you have after anti-TNF failure, ustekinumab is a good option. Vedolizumab was not so much tried in our study, but it was tried in the Reprevio study, and we show clearly a benefit. Now we will look in the cohort what is the best, and I think it's a big area where we need more data and to define what is the best treatment. I think clearly we need to consider biologic exposure before surgery. If there is clearly biologic failure, we should not just use the same. We should probably go to switch out of class, to go to another class of therapy. And we need to make progresses on that and to define what is the best treatment after surgery.
I think this was a perfect conclusion, because prioritization in IBD of biologics is difficult anyway. And here we do not have the data. We have no head-to-head trials.
Yeah.
We have historical data. We have different endpoints. Probably we can prioritize a little bit according to the patient profile, older patient, younger patient, comorbidities, and everything of this. But most of the biologics that have been assessed in this situation will work. So this is probably what we can summarize, or?
Yeah. And maybe we can work on, if we are able to identify subtypes, we could identify what is the best targeted therapy for each subtypes, if we are able to do it.
Matthieu, it was again a great pleasure to discuss and talk with you. I think we have more topics to discuss, and thank you so much, and hope to see you soon again. And to our audience, I hope you found this very interesting and exciting. You may like us if you are happy to do so. And if you have more interest, just watch the next episodes. There are many more to come. Thank you.